morning, everybody. Thank you, Professor Shapira. By the way, time flies, but Mirela joined our clinic 7 years ago. I would like to thank MIS, our friends in MIS, for beautiful time that we have together for the last 4 years, for letting us the honor to be here with you, and for the friendship, hopefully for many years to come. Ladies and gentlemen, let's start. Well, the question is always, how can we get from such a periodontally involved tooth into the final outcome that we look both aesthetic, but with biologic integration that will stand for a long time? The patients usually ask for aesthetic harmony, but we as dentists would like to have it both. There are some gold standards that are based on our experience and also the dental literature that we try to follow in order to maximize the bone and soft tissue stability. Today we try, in most of the cases, to thicken the soft tissue or the biotype to get more volume that will stay there for many years. At the same time, we are trying to augment the socket either during extraction with rich reservation procedures or afterwards. So we know that we try to augment the bone scaffold. We are trying as much as we can to minimize the surgical trauma during the different surgical steps. We understand today that we would like to use for our own advantage some smart implant systems, and very important, as you will see during those 2 days, to place those implants in the correct 3D positioning. And last and not least, we need to pay attention to the prosthetic over those implants, the occlusion, and master all the prosthetic steps in order to get to the final result. So all this together is actually part of what Professor Shapira just mentioned. We are trying to let the tissues with undisturbed vascularization during every step that is surgical. This will lead to cellular vitality, whether it is the bone or the soft tissues. And this is how we will get the tissue volume that is so crucial around implants to let these areas stable for the long time and not resorb or recess. This is the VCONCEPT. And the algorithm of the VCONCEPT is based on several parameters. We are trying to have a control relationship between the shape of the implant and the shape of the osteotomy that is created by our final drills in order to have optimal biologic compatibility. This means that we are trying to create the right chambers between the bone and the implant to fill up with blood, because we know that the neoformation of bone will be the best when it comes from and originates from blood. At the same time, we don't want to lose our primary stability. So we designed those contacts between the implant and the bone for the adequate primary stability. We, as you understood, think that decreasing or even eliminating the pressure on the cortical bone is crucial for long-lasting bone. And of course, when you have less titanium, this component will be replaced by bone. So when we go to simple cases like that, when the ridge is already wide, is healed, then there is no problem to place an implant there. And we all know that. So the V3 implant is getting into the bone as we turn it, and we decide where we would like to place the flat surface. And this is how you can see the gaps filling up with blood, which will turn to be bone later on. And 3 months later, you can expect uneventful healing and very nice soft tissue around the implant head. And we will go through the gold standard of screw-retained restorations. And this is what you get after 1 year. And when you look at the radiograph after 3 years, you see that the bone is stable, even above the connection of the implant and the prosthetic component. Now, in the posterior zone, and when you have wide ridge, this shouldn't be a problem. The question is, what do we do when we have a situation like that? This is the smile zone, and you can see the sinus tract there. So it is a case of a hopeless, non-restorable central incisor. There are some other problems like the uneven gingival line, some old restorations, but this site is periodontally compromised from the beginning. So when you look at it and when you try to draw a line of the buccal bone, we see that we start from a deficiency.
So from the beginning, we are trying to control those factors that we think that actually can influence and have a high impact on our predictability of the final treatment. So like in this case, we will try to reduce the inflammation that we are dealing with at the initial phase, not only the inflammation, but the infection that we have in this site. And more than that, we will try to create the optimal conditions that will require for the ridge preservation procedure following. And this is what we did. At the beginning, we just did for 2 weeks a local antibiotic injection. It's a slow-release antibiotic. It's called Ligozan. It's a doxycycline-based, 14%. And you can see immediately after the initial treatment that we already got much nicer soft tissues. So we have already a better initial beginning for our procedure. Following that, we just addressed the hard tissues. So there was just a fill-up of the socket with the bone substitute and just a collagen sponge with a cross mattress suture just to stabilize everything in place and let it for healing. This is what we got 6 months later. So we can see clearly that we managed to maintain the volume of the hard tissues, as we can see on the CBCT and also on the periapical X-ray. But then, when it comes from the prosthetic planning,
it's a problem because I would like to go for a screw-retained restoration. At that time, we didn't have, like we have today, the angulated screwdriver with the dynamic screw that enabled me to get to the screw from an angulation. So this means now that I need to place the implant at the same long axis of the chimney of the screw, and this must be at the cingulum of the future crown, which means that in this case, we need to place the implant outside, beyond the envelope of bone of the patient.
So already we decided that at the time of the implant placement, we have to augment the area. So we have to proceed with the guided bone regeneration procedure. And we know that there are, in order to be successful in this kind of augmentations, there are some criteria that we have to follow. And some of them were really nicely emphasized by Professor Shapira at the beginning. And these are everything has to do from the beginning, the way that we design our flap, the way where we place our releasing incision. How do we think that we were able to cover and get mobility of our flaps at the end of the procedure? Second of all, the materials that we are using, the kind of barrier membranes. We would like to have a long-term barrier effect of the material they are placing. The stability that we were going to have to give to the graft and the barrier together that can be achieved by suturing or pins, screws, and the combination of the two, actually. The vascularity that we need to provide for the entire complex. And of course, at the end, our intention is always to get primary healing. So for this, accuracy in the way that we suture, accuracy in the way that we design our flap is crucial. So this is what exactly we did. After the implant was placed, as you can see, we had a pretty large area that we need to cover with bone. We placed the bone substitute material. As you can see, it is designed only in the area where we are missing. There was no over-contouring intention for the hard tissues in this respect. There was, I skipped one slide. Yes. We used a highly cross-linked collagen membrane, O6+, that was previously mentioned, and in this case also everything was stabilized with the periosteal sutures from mesial to distal, also from buccal to the coronal, to the apical part. This was the result at the end of the surgery. Always our intention is to get free tension in our flaps. We use very microsurgical instruments, we use microsurgical sutures. Everything is tension-free, and the design of the provisional restoration is not less important. We know that there is, in the early stages of healing, there is a swelling in the area. We do not want our provisional restoration to compress. We do not want any pressure in the area that we try to augment. Then we took a CBCT 5 months after the surgery, and we decided to wait about 11 months until we proceed with the treatment. The reason was that we knew that we had a high amount of bone that we had to regenerate. So we decided to prolong the waiting time to let the tissues mature. So this is what we had, and when we look at this image from the frontal view, we can say, well, we have nice contours of the soft tissues. We can see that everything looks pretty nice. But then when we look from the incisal view, and I think this is even a more important image, we can see, well, we do have a deficiency. Now, we saw that we do have enough hard tissues on our implants, so the deficiency that we are dealing with is mainly related to the soft tissues. Then we started to analyze it. And we see, obviously, we have buccal convexity deficiency, as we can see on the left side of the screen. But then we have also another one, the papilla area. Not only on the palatal one, but most prominently on the buccal part. So this is a very important step, because in this situation, we are going to decide which type of an uncovering procedure we are going to perform later on, which kind of soft tissue graft we are going to approach. In this case, I went for a roll flap technique, which retrospectively, I think that I would have gone for a different procedure, and we were going to see later on why. But this was my decision at that time. That part was slightly deepitalized, rolled inside of the buccal, and this was 2 months post-connection. And we can see two things. One thing is that we see nice convexity, but in the central part of the buccal aspect of our implant, and we have a deficiency. And this has to do at the base of our papilla.
So as you can see here, this was the screw-retained provisional on a titanium sleeve. And then when I remove it, I see the nice convexity, which resembles kind of a root prominence of a natural tooth, which is very important in the smile zone. And this is something that we always need to opt to. And if you look where is the implant situated, you see that we were able to achieve more than 3 millimeters of tissue volume buccal to the implant head. Whether it is combined of 2 millimeters of bone and 1 millimeter of soft tissue, or 1 millimeter of bone and 2 millimeters of tissue, and sometimes only soft tissue, it is not so important, as we know. The problem is still at the distal papilla. So here, there is an issue that we will need to take care of.
So as I said, when we analyze our deficiency, we will try to understand which type of grafting procedure are we going to approach. So we know that we have different areas from the palate that we can go to, with the posterior, the tuberosity, to perform the traditional subepithelial connective tissue graft. All these areas are different in terms of the tissues that we will receive. And we are going to choose the right one accordingly to the amount of volume that we are going to need to create. So in this case, as we saw, we already had enough volume. We didn't need more volume in the buccal aspect. We needed just at the base of the papilla. So we went for a free gingival graft that will be deepithelialized, and we can see that already after we took the graft, we had 4 millimeters of thickness, way too much. So we decided to slide it. We went for a tunnel approach. In this case, we undermined all the area of the base of the papilla, the area that we like to augment. Of course, we had to release mesial and distal in order to create space for our tissues, to insert the tissues. And this is what we did with a small suture in order to stabilize. Regardless of the procedure, we need to stabilize our graft, regardless if it's a soft tissue or hard tissue. And this was immediately after the surgery, and we can see we got a very nice immediate change of the shape of the arch. From a concave, we got immediately a convexity. And more important, we know that soft tissues in time, they look better and better, they mature. But this takes time. It's a process that takes up to a year.
Look now at the distal papilla right after surgery. It is still missing, and even the mesial papilla is still shorter than the papilla between the natural 21 and 22. But we already placed the seed, the genetic seed for what will happen. So I can make the impressions, and this is a traditional, conventional elastomeric impression 2 months later for both teeth, and we are going now to follow the diagnostic wax-up with the formation of the definitive crowns. And these are the 2 definitive crowns that were made by Vincenzo. 2 monolithic IMAX restoration. The restoration over the implant is actually a hybrid restoration with an internal core and then an external monolithic IMAX that will be bonded over it. We will show you later on how we do it. Tomorrow, Galip Gurel will show you how we do it. This is how it looks like 1 year after delivery. We can see the nice, even the exaggerated buccal convexity. But what is more interesting is what happened to that papilla. After 1 year, this is what we see. The mesial papilla is still shorter, but this is how it looks like just 1 week ago. So we can say that understanding biology and trying to execute it in the right way can lead you to a nice result. Now, this patient has a low lip line. Still, we went through all those procedures because this little triangle there, even when she smiles, and this is where the upper lip hits, would be a big problem if it would have been missed. And again, you look at the side on the integration of the implant crown and the natural tooth crown, and you can see that this can be described as a successful result. The second and last case is an interesting case because I started to treat this patient almost 10 years ago, and number 11 was questionable, as you can see here. The whole site was periodontally compromised, and we decided together with the patient to take our chance and to replace those deficient restorations, although we knew that there might be a problem, especially with tooth number 11. Now you look at the bone level, and you see the pocket depth and where is the bone over there. And I know that if I have to remove that tooth and place an implant, this will create a big problem because the peak of bone is already resorbed. So we decided then, 10 years ago, to try and save the tooth. And it really went well for some 8 years. But unfortunately, after 9 years, the tooth broke. And the whole complex of the crown and the inlay core came out, of course. And now there was a question whether I'm going to place there a bridge with a pontic or an implant to let her have single units as she demanded. And we decided to try and go for implant placement. But when you look at the CBCT, you see that we already deal with very narrow ridge. So there are 3 issues, main issues that we have to try and deal with. We have a tooth that needs to be replaced by an implant after it is removed at the smile zone. We already start with deficiency of the hard and soft tissues. And the question is, are we going to remove the tooth and place an immediate implant, wait maybe a month or 2 and place a delayed implant, or wait for more time, maybe 4 to 6 months, and place late implant?
And then we try to set up our goals for this case. So by analyzing how do we start with, and Nitzan already emphasized it, that we were already deficient also in hard, but also in soft tissues. So we went for a delayed approach or late approach in terms of implant placement. But then the question will be what we will do till the time of the implant placement, from the time of the extraction till the implant placement. So we decided that we are going to try to preserve whatever we have at the time of extraction. So we went for a rich preservation procedure. Our goal was also to satisfy her need, as Nitzan emphasizes. She would like to have single teeth, as she called it, or single restorations. So a late implant placement, and we will see at the time of the implant placement if we will need any additional augmentation procedure, hard or soft tissues. And then, of course, as always, we will try to be as minimally invasive as possible in all our surgical techniques. This is what we did. We started with a rich preservation procedure. We addressed only the hard tissues. We decided that we are going to analyze the amount of soft tissue that we will have as a deficiency and approach that at the time of the implant placement. So we just placed a highly cross-linked collagen membrane, similar technique like the ice cream cone technique of Tarno and his group. Just fill up the socket with the bone substitute, close everything. No intention for initial primary healing was aimed. This is what we did. This was 7 months later. And we can see on the CBCT that on the coronal part, which is the area that we try to preserve whatever we had, and if we could gain some more, would be very pleased. This is what we had at 7 months. But then,
as always, there is the unpredictable factor. Our patient is a surfer. She likes to surf. And one day she went to have her hobby, and she was hit. Luckily, only the provisional bridge broke, and another tooth. So we had our original goals. Now we have to reset it. We have to adapt, because this is something that happens almost in every treatment. Now we have number 22 that is heavily broken, and we need to take care of it by removing it, and we will go for immediate placement because the site, the bone, is still healthy around it. It is a structural problem that causes us to replace the tooth with an implant. So we need to understand that when we implant any type of implant in a periodontally involved site is not the same that we implant in a healed or in a healthy bone, where the cause for the removal of the tooth might be decay or any structural deficiency. This is a completely different ball game, and the way that we're going to treat it is different. So here, this is the provisional bridge. Before the surgery, we see the very narrow number 11 ridge. This is 22 that we're going to replace. and now I'm planning where to place my implants. And again, I would like to have a screw-retained restoration in both sides. So when I'm planning number 11, it will go a little bit beyond the bone at the apical part, whereas 22 is straight inside the bone confinements. Again, 22 is okay. This is the starting point. We are going to remove 22, immediately place an implant, and of course we do it very delicately with periotomes, with some elevators. This might take you more time. Sometimes we use some additional instruments to remove the root, and after the root is out, then I can take my M-guide, place it on the adjacent teeth, and start drilling for my osteotomies. So at the socket, I can start immediately with the long drill because there is no bone to stop me, and you go as you need, depending on the implant that you choose. Here, it's a narrow implant, so I don't need to enlarge the osteotomy. I place the implant manually, and then I torque it down with the torque controller. And of course, it depends on the bone, but it also depends on the relationship between the implant and the osteotomy that was created previously. Placing the cover screw, we like to use some chlorhexidine gel before we place anything into the implant. We go to the next site. Here I start with some short drills, and then I enlarge and deepen the cavity, the osteotomy, and at the end, we will use here the final drill that is coming with each implant of the V3 system. We will place the implant, as you see here, and you can expect the apical part to protrude through the bone, as was planned additionally. And because I would like the implant head to be more or less 3 millimeters apical to the future CEJ, at this time we double check that my planning was correct, and it is correct. We just need to remember that CBCTs are not 100% foolproof. So if you rely only on CBCTs, sometimes you might find yourself with some surprises. Here, Mirela comes into the picture.
So as we planned from the beginning, we knew that we will have to proceed with a GBR procedure for that area, that we had some threads exposed, and we followed the same principles of using long-term stability of our barriers, bone substitutes, stabilize everything in place. We augment only the specific area that it was deficient. We stabilize it again with sutures. We will add, of course, some xenogenic material in the area of the immediate implant because we know that there are going to be some volumetric changes that are going to happen after extraction. This is biology. So we will try to reduce the shrinkage volume there. And we are using always PRF, but just because we believe in the potential for the better healing for our patients. The
Initial healing.
Initial
healing. We don't know what happens later on. Yeah.
We always aim for tension-free closure to have the best healing that we could achieve.
So we go through all these surgical steps for one reason. We would like to have the best environment for those two guys, those two implants, to be able later on to end up with the best possible aesthetic result in these circumstances. So we waited, and then we go to the uncovering. But again, there are some things that we need to notice.
So a few months later, we went for the uncovering procedure, and again, the same protocol. We are going to analyze before we start. We think twice before we cut. So we started to understand what will be our deficiency. So in 2 dimensions, we have first, in a vertical one, more pronounced, of course, in the area of tooth number 11, where we started with the deficiency. A little bit less in the area of the immediate placement. Everything was in place, so we only needed to preserve. And then we look at our images also from the occlusal view, from the incisal. And then we see that we do have to augment also in an horizontal way, also in that area of number 11, and then also in the area of number 22. Then the question is always what kind of procedure, which way to go, what kind of graft to take. So what we did at the time of the uncovering, as you can see, we took also digital impression. The reason for the digital impression at this stage was that we wanted to enable to have for our patient very short time for delivery of a provisional restoration. We wanted to support the tissues after the few days after the uncovering. Then we went for a tunnel approach. Again, we undermined the area, the buccal aspect of the two sides. We always go mesially and distally, more towards the area. We use microsurgical instruments. And I think this is very important. They give you a lot of precision. They are very sharp. You can be very precise and very atraumatic for the patient. And this is what we did. This is actually the virtual model that you can see after our digital impression. And we can already see in the image where we see the body scans, the convexity of the area of the buccal aspect of tooth number 11 and 22. And this was our aim, to increase the volume in those areas. So we went for a free gingival graft in the posterior area from the palate. The same procedure. The reason is that we want to have thick tissue, dense tissue. We don't need a lot of volume. We don't have a big deficiency. But we want that tissue to stay there. We don't want it to resorb fast. So we would go for an area that we know that we will get a very tense connective tissue. This will be deepithelized. It's a little bit time-consuming procedure. And then we divide the two grafts accordingly to the site and the amount of tissue that we need. After everything is being tunneled and undermined, we are going to insert it, gently push the tissues in the tunnel that we previously created. Everything is being stabilized with resorbable sutures. And at this time, because we knew in 2-3 days we are going to provide for the patient new provisional restorations, healing abutments were placed.
Actually, the healing abutments help also to locate and to stabilize the graft. And we have different types of healing abutments. We have narrow, we have wider, we have concave, so we can play with it. This is how it looks like right after the surgery. We can see the gingival line. Have a good look at it because we are still missing, of course, the papilla, distal papilla of number 11. And then, as we took the digital impressions, we need now to create a model. And the model is going to be 3D printed, cellulolithographic model. How do we place the analogs of the implant in this printed model? There are different ways to do it. One way is to create a jig of the implant analogs adjacent to the teeth, and then drill a hole into the printed model and place the analogs as we did in this case. So together with Julie Cooperstein, we have now the model that was completely printed digitally, and Julie is going to provide us with CAD/CAM composite-based restorations, both for the natural teeth and for the implants. So here we use Telio as a material, and the important thing about it is to understand that we are going to have some tissue swallowing afterwards, and I don't want to compress it too much. So the submergence profile and the emergence profile, the profile of the implant restorations under the gums and supragingival need to be very carefully planned, because I wouldn't like to compress the tissue under the gums. This is why it is always narrow there in this type of treatments. And more than that, you see that we left the gingival embrasures open to let the papilla, hopefully, to start filling it, but definitely not to compress it. So this is after 1 week of the provisional restorations in function. And now we wait. We wait because we know that the seeds, the genetic seeds that Mirela implanted are there, and it will take some time for them to have some expression. 6 weeks later, it looked like that, and I decided that we go for the final impressions. So here, we decided to go at the analog, conventional way, because it depends also with the technicians that we collaborate with. Some of our technicians are more into digital, some of them are more, I would say, traditional, and we have the possibility to play whether we want digital or conventional analog way. Look at the volume that we were able to achieve buccal to the flat surface of my V3 implants. Both sides are more than 3 millimeters, and this is imperative if you want to be at the safe side for long-term stability. So we took an elastomeric impression with a closed tray, implant transfers, and this is the impression. And now we are going to design the cervical profile of our restorations. We have the plaster model. At the same time, we have also the ideal diagnostic wax-up. I would like my restoration at the end of the story to look like that. Now, there is a discrepancy between the tissue size, the tissue positioning, the architecture of the tissue around my implants, the model, and the ideal shape of this gingiva at the diagnostic wax-up. And I would like to guide my technician towards the ideal shape of the teeth. So we are transferring the lines from the diagnostic wax-up into the actual model. What do? We take a duplicate of the wax-up in plaster, and we mark the gingiva line from buccal and palatal. Then we have silicone indexes that we position on the model, and we will change in the model the shape of the peri-implant envelope towards the desired ideal shape. And when we get that shape, then the technician will need just to fill up with the material of restoration that we choose and let the tissue adapt to this ideal shape. So this concept has been described by me in the literature for more than 20 years ago. And for more than 20 years, this is what I prefer to do. I do not like to waste my time chairside with the provisionals. Add here, take it out there, try it in, put it again. Why? If you know that you have a surplus of tissue, of soft tissue, then let's design it on the model. And this is what we did in this case. So you can see that now our technician can start placing and designing the different components in the newly designed peri-implant envelope. And not only that, according to the cervical contouring concept, you don't only take away some material, but if you think or you designed to have even larger papillae, please let it be on your model, and we can add it easily with wax, and design the proximal contours of your restoration accordingly. Of course, you need to be experienced to know what might be possible or not biologically in your patient's mouth. So, as we see here, the implant restorations are hybrid again. We have a zirconia core, and then we have an IMAX crown that Mirela bonded together to end up with one screw-retained restoration that is composed of a thigh base. In the anterior part of the mouth, I don't like the short thigh bases, so we prefer to have the long titanium sleeves that originally are for provisional restoration. They function excellent also for the definitive restoration, because you would like to have the titanium sleeve as long as possible in the anterior zone, not to let the ceramics detach from it during function. And then, after we have the definitive restorations, our technician, Stefano, is going to layer the IMAX superficial restorations in order to have better aesthetics. So these are actually the definitive restorations: 2 layered IMAX on natural teeth and 2 screw-retained for the implants. This is how it looks like 4 months later on. This picture was taken just before we left Israel. So 4 months, of course, is not enough for complete maturation. It's just the beginning of the healing of the tissue around those restorations. But still, it looks not bad. Because if you decide to make a true comparison from where we started 9 years ago and all the journey that we went through this patient and where we are standing today, just 4 months after placing those restorations, you can look at it and know how it will look like even in 6 months, in 1 year, in 3 years. So ladies and gentlemen, open your eyes. I know it's early in the morning. Yesterday we went to sleep very, very late. But this is very interesting. When you compare the periapical radiographs and you look at the distal aspect of the lateral incisor, where we started with this peak of bone deficiency, after all the procedures that this patient went through, I can see something that looks like lamina dura. I don't know whether it is a PDL or not, but what I do know is that we have a functional, stable papilla in this region. 4 months post-op, we start having the stippling in this region. I can guarantee that in 1 year, and even better in 3 years, this will look even better. So these are some of the concepts that we do in our everyday practice. You know, in the coming days, today and tomorrow, we will be exposed to some of the best dentists in the world. And the question is, what makes these people extraordinary in their profession? I don't think that it is just the talent. I think that what makes you better are different qualities. I think that your attitude is very important. I believe that your dedication in any profession, especially in dentistry in this time, is of primary importance. I would say not only dedication, maybe even obsession. You are trying constantly to improve your skills. You make efforts for that. You are coming to Barcelona not only to go to the different beautiful events, but you stay here now. And this is very important because we are trying to expand our knowledge every day as we can. And we share. We share. But the driving force behind an extraordinary professional is very simple and actually is emotional. Our driving force is our passion. We thank you very much.